Greetings to all of our AACP members, friends, and visitors. Today we have the pleasure of hosting Dr. Stephen Olmos and Dr. Ed Lipskis. The format for today's webinar will be a dual presentation by both featured presenters, followed by a Q&A session. Please enter any questions over to the right in the questions segment, and I will address those at the end of the presentation. There will also be questions posed throughout the presentation for attendees for CE purposes, as well as a post-webinar survey to include information in order to receive your certificate. So without further ado, I'd like to introduce Dr. Stephen Olmos.
Well, thank you, and good morning, everyone, from the comfort of our homes. We'd like to say that these unusual times are giving us an opportunity to catch up on some things that maybe we wouldn't have to. Some of the things we said we always wanted to do, like stay home with our family and cook home quick meals, and just be with our family and figure out what are the real important things in life. It also gives us time to read and educate. So hopefully you'll find today's webinar of interest. I'm really pleased to be here with Ed and his vast knowledge. I'm going to do a little intro, basically to explain pathophysiology, talk a little bit about screening, how we diagnose, give some examples of how we treat the younger children, the 2 to 5 range, and then Ed's going to give us all the meat of the information on how to treat the older children. So I think we're excited to get started. So let's do so, and we're going to have time at the end for some questions too. Okay, so I'm going to turn off my webcam and okay, well, yeah, so pathophysiology we want to talk about. When do we start? When is the proper time to do screening? And what are the consequences of these disorders? So I'm speaking to you not only as myself, but as I'm going to share some of the protocols and things that we use in our numerous centers, almost 65 around the world in 7 countries, and give you a little insight as to the thought process. I guess we should start back last year with the 2019 Nobel Prize in Medicine, which was all about how our cells adapt to various oxygen levels. And so these 3 gentlemen were awarded this honor because they were looking at the development of conditions like anemia and cancers based on how red cells adapt to varying oxygen levels. So if we're going to talk about obstruction in airways, we're going to talk about oxygen levels and CO2 levels. And particularly the kidneys. Kidney cancer is of great interest because that's where the response to decreasing oxygen levels produces erythropoietin, or EPO. And this stimulates the production of more red blood cells that carry more oxygen. And specifically, it's the protein called hypoxia-inducible factor. And this is what stimulates the parts of the DNA to produce this EPO. And these are stimulated when there is a decrease or a hypoxia. Now that we understand how the body regulates oxygen uptake, we can understand how various cancers are being produced through the protein called tumor suppressing protein, or VHL, which ordinarily causes this to break down, and as a result, they get misshapen and produce cancers of the kidney. So understanding how to reverse this, how to change, and what is the propensity. Previous studies have shown us the comorbidity between cancer and obstructive sleep apnea, and we're understanding better exactly how that mechanism is triggered. So if we start at the beginning, well, what's proper breathing? Well, obviously, proper breathing is through the nose. The nose is the organ for breathing. but how do we measure whether or not that's working properly? So there's some recent articles talking about how to measure this, and talking about using peak nasal inspiratory flow and how can we measure that. So the picture here shows a nasal valve, so a normal nasal valve open, as opposed to B, either with a nasal valve collapse or compromise that restricts nasal airflow. And this is showing a little device called a mini peak nasal inspiratory flow meter. There's certain rates that are normal. Generally, men have a higher rate than women in various studies. And so this is a quick and easy way to check respiratory flow. And it's inexpensive, doesn't require computers, has a correlation, a coefficient of 92%, and it'll give you the information immediately. And basically, it's the result of 3 maximal inspirations and what is the highest rate at that point. The important thing, and to include in this presentation, is that you can use this on children anywhere from 6 months to 8 years of old in one study, and they notice that as kids grow and age, they have a linear increase in this PNIF figure, and so they can then see whether or not the child is in a proper percentile or a lower percentile, in which case it can direct treatment. And these are the kinds of things that I've been involved with in the last, I'd say, 1.5 years, almost 2 years now, looking at nasal function. We do all these therapies, and we suspect by subjective behavior that we've improved or corrected things, but how do we really know that we're making a difference, and have we restored it to norm? So things like rhinometers, which measure volume, and other devices called rhinomanometers, are measuring flow rates. And so this is some of the equipment that we use. This is a GM instrument. Our research carries this device. It allows us to measure flow rates. So whether adults or children, so you want developmental stuff for kids, okay, well then, are you actually developing that nose in the way, or is nasal surgery going to be, if they have nasal surgery, did it restore to norms? The assumption is that it does, but it's been my experience that it usually does not, and that's where we go back and request revision surgeries. So this is a way to measure not just volume, which is rhinometer, but also flow rates. So this research is showing us that however you manage these things, you should check to see whether you have nasal obstruction. A paper that just came out a couple months ago was authored by Sarush Zahi, who's the ENT from the Los Angeles area. He's lectured to our AACP at our annual meeting. And this is a great paper from a number of facilities around the world. And it's a very simple test to see whether or not a patient has a nasal obstruction and is mouth breathing. So simply put, they had over 600 participants, and the majority of them were children. And a very simple test, what they were doing is they're just using this myopore breathable tape and measuring to see if people could be comfortable breathing through their nose for 3 minutes, 180 seconds. So as I was saying, over 633 subjects, of 315 of them were children 3 to 11 years of age. So they checked adolescents and young adults and seniors, and it was pretty much consistent throughout the age groups that that if a person can't breathe for 3 minutes through their nose, then that was clearly a nasal obstruction condition that requires therapy. So some simple ways to figure these things out. So the question is, if we have pediatric OSA problems, well, then when should we start screening? And this paper that came out 4 years ago in the journal Obstructive Anesthesia talks about sleep disordered breathing seems to occur with a prevalence of 15% in healthy obese pregnant women and 50% in high-risk pregnancies. So every other high pregnancy with risk has a respiratory related problem. And in our 2017 symposium, when we had the pleasure of hosting Dr. Christian Guilleminault, the world expert on pediatric OSA and a big proponent of dental collaboration for its treatment, the man who developed the whole AHI system, which he was very clear that he doesn't believe in and is oversimplified, but he had to make it simple for physicians or doctors, he says. And what a great man. Unfortunately, we lost him last year, but his literature and thought process still is powerful. Here's a paper that he was alluding to, obstructive sleep apnea and the risk for adverse pregnancy outcomes, and talking about this a fetal facial profile. And so in the frontal to mandibular position, this angle, if less than 65 degrees, is a clear sign of a sleep disorder breathing outcome. And this is something that we've seen consistently. This is some slides from Kevin Boyd, who gave me these slides about pediatric cranial development. So here's a normal child in the 19th century, as opposed to what we're seeing today with these retrognathic angles. And that's what Dr. Guilleminault was saying, is that if we have these facial angles less than 65 degrees, that we're likely going to have a baby with a breathing disorder. So screening should really happen during pregnancy. I even think before families are deciding to develop, when parents are ready to develop a family, this is a time for screening, because there's so many consequences. So untreated sleep disordered breathing is associated with preeclampsia, gestational hypertension, gestational diabetes, and severe maternal morbidity. And preeclampsia is a very serious situation at risk for mother and fetus. And this is where you get these episodes of hypertension, 140 over 90 millimeters of mercury or greater, documented on 2 occasions, at least 4 hours apart, is definitive. The signs and symptoms are going to be, urine proteinuria, severe headaches, changes in vision, upper abdominal pain, nausea, vomiting, decreased urine output, thrombocytopenia, impaired liver function, shortness of breath. So these are severe complications that we really need to take a look at. Evidence of placental hypoxia as a result of these breathing disorders creates a fetal normoblastemia. And we see that whether there's snores or OSA compared to non-snore controls, the very dramatic difference. There's almost 35% presentation in snorers, 56% presentation in mothers with OSA. So this is a very severe consequence, because basically what's happening is that these immature blood cells are being released into the vascular system and basically leaking out of the bone and penetrating through very small portholes in the bone marrow barrier. So this is showing a peripheral blood smear of these immature blood cells. And as a result of the anemia and also decreased oxygenation can be a serious problem. Some of the consequences of maternal OSA is babies that are born with a that are small for gestational age, and that is directly related to decreased cognitive function. And so in this paper, they're showing that verbal as well as performance IQ are significantly reduced in mothers with these kinds of breathing disorders. And that the definition of a small for gestational age is when the birth weight is below the 10th percentile. And so these studies show us that there are several studies on preterm born children have identified birth weight as a potent predictor of later cognitive functioning. So we really need to understand all the sequelae that is going to be lifelong for these children, and why we want to work together and build bridges. That was what I was trying to do back in 2015 when I had a pediatric sleep clinic at the University of Tennessee, when I was working with the physicians over at Le Bonheur Hospital down the road from the dental school. And we hosted meetings to try to build these bridges. And one of our lecturers was Layla Gazelle, whose husband is David Gazelle, and they are both from Chicago, world experts in pediatric sleep. And we asked her to talk about systemic inflammation and vascular dysfunction in kids that have OSA. We know that adults are going to succumb to these kinds of problems because of the consequences and comorbidities with the cardiovascular disease. But is there a different mechanism for children? That was the question. So this is a flow chart that she presented, and we looked to the left to see that, well, how does the upper airway occlusion, how does that affect cardiovascular health? Well, as a result of the obstruction, there's increased resistance for the left ventricular pressures that are built up, so it's harder to pump the blood out in these situations. Because of the hypoxia, we're going to have increased loads in the body's responses to produce cytokines, which are inflammatory throughout the vascular system. Also, there's an increase in leptin, so then the patient becomes leptin intolerant or decreased response to. So as a result, they're hungry, and so they're going to continue to eat more. And obviously, the more they eat, the more they worsen the problem. But the real culprit is the arousal mechanism. So as you wake up from trying to breathe, not complete consciousness, but disturbance of sleep, this produces a systemic oxidative stress, and that begins the process of thickening of the blood and cardiovascular disease. The increased sympathetic activity means you have an increase in blood pressure, heart rate, cardiac output, and tachycardia, and that's going to increase O2 demand. So if you have greater O2 demand, but you have less O2, this now compromises the myocardial ability, and therefore cardiovascular disease begins in childhood. So I guess the message here is that if you have OSA, you've had it your whole life, you were born that way, you likely inherited it from your folks. And so this is good in our screening to identify that for parents and children. We were trying to look for solutions because we were wondering, is it possible to cure this problem? And that's still what we're trying to determine. Can we make changes? Can we improve? Are they lifelong? That's what we're still trying to find. The problem is getting a diagnosis. If we screen kids, can we get them into a sleep facility to get a PSG, which is still the gold standard? However, it becomes more and more difficult the greater the numbers. So now looking at portable monitors to see whether or not those could be used. And this paper that came out last year in the Journal of Clinical Sleep Medicine talks about using the Byte, which can be used for children and adults, so it's a universal tool, and how it was found to be important in being able to diagnose moderate and severe apnea, especially the older kids. So this now can maybe be used, and all dependent on the sleep physicians to make that call. So what's the criteria for pediatric dental sleep medicine? This is an article that was published in the Journal of Dental Sleep Medicine about 2018 talking about, well, what is the definition? The medical legal definition is from birth to 18 years old, but is that really the criteria? If you talk to sleep physicians, they say that the sleep of a child resembles adulthood somewhere after age 14, so depending on gender. So a little bit of understanding that we've really got to look at this in an individual way. I was always interested in the thought process of how we define the craniofacial structures that change. In other words, this is a great paper on basically looking at gravitational forces and negative pressure as the cause of craniofacial distortion. It starts out in the abstract talking about the fact that the conventional cause and effect follows an inflammatory infectious process that results in tonsillar adenoid tissue growth, and then airway obstruction and mouth breathing and obstructive sleep apnea are the endpoints. Altered facial structure, adenoid faces, and all of this come. And in this paper, they say, however, through our lifetime of clinical research, Christian Guilleminault and his colleagues have challenged this paradigm and is saying that actually there are other factors in the equation. And understanding, well, what is a mechanical process and what is a neurologic, because that's what we want to talk about today. So if you look at the septal cartilage, the ethmoid, the vomer, the pterygoid plates, the maxilla mandibular, in A, that would be the proper relationship that we would be shooting for. In B, this is what we're seeing in these mouth breathing cases in people with apnea, where you get a counterclockwise distortion of these things that makes the nose look more profound. So what actually might be a mechanism for cause? So in A, it's showing you that nasal breathing, the only negative pressures are in the oropharynx and probably where the tongue and the palate meet. However, when you have nasal obstruction, you have multiple negative areas and of pressure, and you'll see in the nasopharyngeal area or the velopharynx that draws the adenoid tissue down into the obstruction. You can see you have multiple negative pressures in the pterygoid area and the vomer and inferior turbinates. And as a result, this might be the mechanism that actually changes. And this might be the formula for correction. If you want a good reference for these understandings, I would point you to this book, Sleep Disorders in Pediatric Dentistry. The editor is Edmund Lipskis, just a tremendous book of the top experts in the physicians in pediatric sleep medicine, as well as dentists that can contribute. In fact, our next presenter has a very good article or chapter in this book, and I would strongly encourage you all to read that. So let's take a look at the differences on kids. So, what are the differences in terms of skeletal relationships and breathing? So in this paper, where they used MRIs on kids that had snoring and OSA, and looked at the orthopedic consequences. And here it's demonstrating, and I'd seen this for years on adults, where I was treating them for TMJ problems, but the cervical x-rays always showed a subluxation somewhere around 5, 6, and 7 with sublux. And this is showing that it's actually subluxation at 4 and 5 because of the relative position of the epiglottis. So it's very interesting how we see this in adults, but where does it start? Here's a child demonstrating exactly the same mechanism. So there's your chronic neck and osteoarthritic changes for the future. Enuresis is a very common symptom in children, adults as well, with severe apnea. The mechanisms are that the diaphragm is trying to draw air in, but if you have a physical obstruction of the oropharynx, there's increased thoracic pressure on the chest, which causes the right atrium to fill with the venous blood. And as a result, the body's sensors then mistake this for a fluid overload and produce a diuretic hormone that causes the bladder to fill. In interrupted sleep of adults, you'll wake up and go to the bathroom. In deep adult-awake sleep of children, you wet yourself. So same mechanisms, different presentations. What's the relationship between bruxism and dental plaque as a result? So a movement disorder, oh, I'm so sorry. Something just happened there.
I think that's one of the questions that Jordan's putting in.
Oh, thank you. So, so sleep bruxism and dental plaque. So we look at movement disorders like sleep bruxism. They directly relate to the plaque and the periodontal disease that we see in kids. Also, we see that insufficient sleep increases the incidence of caries and deciduous teeth in children. And so basically oral health and oral health quality of life is reduced in children with obstructive sleep apnea. So the ones that we're doing more dental work on are the ones that also are suffering from breathing disorders. We should understand that this is also a neurologic problem because the airways of children who have apnea behave differently than the airways of children that do not. And so I'm sorry, I don't know why that is doing that. Okay. And so this is demonstrating the narrowing of these these airways. So children with apnea, they put their heads in different positions and their airways change, whereas kids that don't have apnea, their airways maintain the same tonus. So we understand there's neurologic differences as well as structural differences, and this is what we tend to think. And the first thing we think of, or most physicians, is if a child is diagnosed with apnea, well, then they need their tonsils and adenoids taken out. And so that's usually the primary treatment. However, postoperative respiratory complications are common among children with obstructive sleep apnea. So kids having these surgeries have high consequences. In this paper, they were really looking at the costs, but they were looking at the frequency. So these postoperative complications, as you might guess, from any surgery, pain, nausea, vomiting, dehydration, hemorrhage. However, respiratory compromise was quite different. That was defined as oxygen desatting lower than 90%, or when they had respiratory distress bad enough to require intervention. So they separated these kids into two groups. And they see that, well, with the occurrence of prevalence rates of whatever 1 to 4% of the US population with apnea, and very good, well documented and literature-based study is showing that TNA surgery is usually first line. But what's interesting is that even though PSGs is the optimum diagnostic test for OSA, in a survey of pediatric ENTs, fewer than 10% routinely get a PSG to diagnose. They just simply go by symptoms, and they never do PSG follow-up studies to see whether or not they have actually corrected the problem. So predictors for kids that are going to have these kinds of post-surgical complications are going to be the ones with a greater AHI, the more severe, the younger age, and the ones that are obese. And certainly medical costs are greater in that, and that was the part of the study. So we know that these are common in TNA, and so that's why we need to look for different solutions. But if there is a really severe problem, then we need to look at because Guilleminault is saying that, gee, maybe these tonsillar problems are the result of the problem, not the origin, and that was the paper that we spoke of previously. So then what are we treating to is the question with kids that have these issues. And what he says is that we need to restore nasal breathing. That's the ultimate goal. In fact, he says elimination of oral breathing, restoration of nasal breathing during wake and sleep may be the only valid endpoint when treating OSA. So why is it so important to breathe through the nose? Well, because of this molecule called nitric oxide, which is extremely important for processes throughout the whole body. Specifically, it is produced and concentrated in our sinuses up to 2,000 times or 200 times greater than in the air we breathe. And the function is antimicrobial, and that's very important these days. It also is a stimulus for the cilia to carry debris out. So every nasal breath, brings this gas into your lungs and prevents infection. In fact, this paper from 5 years ago talks about nitric oxide, how it inhibits severe acute respiratory syndrome in a coronavirus. And treating people with nitric oxide dramatically reduced. And this is of particular importance to us these days. So nasal breathing is your protective mechanism. So we have pediatric sleep problems, and we should understand that it doesn't matter what the BMI is. You can have big kids, you can have kids that are skinny, but when pediatric sleep disorder breathing is present, there's abnormal collapsibility of the upper airway, and it only gets worse with weight. They have different presentations. The thinner kids have more cognitive issues. The heavier kids seem to have more cardiac type problems. So over the years, if you look at follow-up studies of TNA, there's not really that many. In fact, this one here is a 3-year follow-up for kids that had PSGs before they had tonsil adenoid and 3 years later. In fact, they had PSGs at intervals of 6 months, 12 months, 24, and 36. And there's no other paper that's actually followed kids that closely and with that good of data. And what they found out is after 6 months post-TNA, about 50% of the kids had normal AHI. However, after 6 months, that number dropped to 25%. So that means 75% of the kids had problems resurface, and that's the issue. Because immediately there's some benefit, but no one ever goes back to check these kids to see if that sustains. In fact, this paper that was published in JAMA talks about the fact that with tonsil and adenoid surgery, the children have a greater risk of respiratory, allergic, and infectious diseases for the rest of their life. And so this is quite a concern because we thought it was a local problem and this is a really big study. 1.2 million kids involved, 17,000 had their adenoids taken out, almost 12,000 tonsils, and over 31,000 had both. And then they followed these kids and they calculated the risks of whether the adenoids or tonsils are both removed in the first 9 years. And the reason is at 10 years of age is the peak of your immune system. And so that was the optimal time to check this. And what they found is that there's a relative risk of asthma, influenza, pneumonia, and COPD. Now, isn't that amazing that you think that, more likely to have a problem with smoking? So, in fact, having your adenoids out doubled the risk of COPD and other diseases as well, with infections in the eye and other respiratory-related changes. So, but here's the interesting thing. Taking the tonsils and adenoids out didn't really have any change in abnormal breathing up to the age of 30 for any surgery, and no change for sinusitis or So taking your tonsils and adenoids doesn't really have any long-term benefit, but you have a relative risk of increase 4 or 5-fold for chronic ear infections and sinusitis. So if you take your tonsils and adenoids out, take your immune system, you're really going to have a greater chance of all sorts of other pathologies. So perhaps there's other alternatives. Now, here's something new for me, the type of laser systems that can be used. So I'm now introducing myself to Fontana. This is some slides from Dr. Amparo David in New England and Boston area, and demonstrating how quickly that you can reduce this, life-threatening situation in some cases, and as a part of your treatment. So, because there are consequences, and we should. Now, this was said that I just saw just a couple months ago. So, it isn't as if there aren't risks for these situations. So, when we look at children, so here's a young man who was a severe apneic, had his tonsils and adenoids removed. However, just like the literature we just showed you, he had symptom return after 6 months. and worsening. So he was brought in. You can see his airway is quite limited there. This is his original sleep study. Right at the bottom there, it says overall AHI was 17.5. He was diagnosed with severe pediatric OSA, and he desatted down to 89%. Now, how does this factor into how a child carries himself? Because posturally is related to airway. And look at this young man who can barely walk a hallway without bumping into things.
Okay, now turn around and come back this way. Gotta walk.
And so taking this airway here and creating a situation of stability for airway patency, as you can see here, to understand a starting point, because he wasn't really mature enough to do orthopedic things, very shy kid, very, so we thought, okay, we're gonna do this in a more myofunctional way and develop things to a point where then we can do more interceptive things. And you can see here in the primary dentition. So, but you can see the nasal compromise, valve compromise, because of the regressive maxilla and posteriorization of the maxilla. So the maxillary zygomas are retruded and there's no support. And here you can see the asymmetric relationships, condyle fossas. And this is how we produce the disc displacement issues. You can see on the left where there's almost no joint space in the AP view. So it's about coming together with a plan that is based on myofunctional techniques, which are based and also, and that's more oral techniques, whereas it must be combined with nasal. And so you come up with a particular formula for that for each patient, along with devices like the Myobrace and this sort of thing, which we use for this child. But then you have to quantify what you do. And so that's where I've really come to measuring CO2 values, because you know, you want to know what the results of your treatment are. So you'll do baseline capnography, then do the exercises, see how much you've improved the net change, and then compare that to treatment as you go through. You give them exercises, but how do you know that they're actually doing these exercises, and are you? So I measure compressive strength and resistive strength, and that's what this little device on the right does. This is just showing you basically how you can quantify the differences in your techniques with breathing, with capnography. And so I think this is a great adjunct to what we do, is being able to actually measure real time, as opposed to subjective, asking the patient or the mothers or fathers, you know, how the child is doing. So each time they come in, we do these measurements, and just 6 months of treatment with management with nasal sprays and different things that we need to do, you'll see this young man has a quite different postural presentation. You'll see the clarity, and if you remember the way he walked down the hallway.
Okay, now turn around and come back this way. Gotta walk.
To the way he did 6 months later. Almost in a military fashion. So taking these children and looking at the symptoms, the malocclusions and the postural relationships, you see the total person changing. And this is the clarity, the acuity, the friendliness. You see their personalities change. You see everything about them. And yes, the teeth as well too. Although that wasn't the direction in this case, that's the endpoint. As you can see, just in 6 months, how the open bite is decreasing and the angulation of these teeth. So now we have a child that's a little more mature, ready to go to the next stage and continue to develop and end up with a severe reduction in these problems that allows us to continue to monitor and see how we're going to continue to improve. So remember, we need to screen. Screening starts in pregnancy, half of all high-risk pregnancies. And we need to understand the difference between the orthopedic problems as opposed to the neurologic. So when we have PCRIT, which is the pressure that collapses the airway, the critical pressure that collapses the airway, is more of an orthopedic. And the muscle responsive, how flappy these muscles are, those are more orthopedic in being able to address those, as opposed to the neurologic, the high loop gain and the low arousal threshold. In other words, what's your respiratory response when you don't breathe? Is it, hyperventilation, or you don't react at all? Low threshold means that, in these situations, are you not responding? You're taking a great amount of time, so the hypoxia is greater. Those seem to be more CO2 related and neurologic. So if you're going to treat, what position would you treat to? And these are some of the things that Ed's going to talk about, changing the orthopedics of it, but understanding what's the neural and what's the orthopedic is important. And that's where nasal exercises and things. So positioning becomes important. As an adult, we tend to move the jaw forward in some techniques to do this. But I've been using this Sylvan phenome technique for many years. I published that in Sleep and Breathing 2007, but we thought, it'd be good to have a head-to-head to see, is it comparable to the traditional George Gage technique? And that was this paper that was just recently published at the end of last year, and found out it's equally as efficacious in helping these patients, but we're not protruding the mandible in this technique. So that would be ideal for these pediatric cases. Put them in a phonetic position, look to then make your changes to that. Because as adults, our therapies to handle loop gain and arousal threshold is medications, and we don't want to do that to children. So that's where these Patrick McEwen, Buteyko thought processes would come into play, and that's why they need to be assimilated, because the pH of the blood is going to be determined the amount of oxygenation, because when even small changes in blood pH significantly reduces the oxygenation. Blood pH from 7.45 carries 65% more oxygen than blood at a pH of 7.3. So these are significant changes. And these DSATs become extremely important, because when you talk about desatting, you get down to something like 65%. Well, that's like being on Everest in terms of the demand on your body. So we have to determine, how do we go about looking to help these kids. I authored this paper talking about three-dimensional orthopedic development, that are transverse theories of arch length is all based on teeth, but how does that factor in with kids with apnea? Because we know for every 1 millimeter of transverse width, we get 2.36% increase in nasal volume. But there's a vertical, if you will, or a height component to it as well, and that's where composite or Planistrax or turbos or whatever you want to call it, the verticalization as well to handle that mid-face deficiency, as well as looking at the maxilla in its AP position. So that was my call. I was saying, because all children who are going through orthodontic treatment have skeletal problems and malocclusions, that they should be screened with a better screening tool, which is correlated based on age, and that's a factor. So we understand that transverse expansion is going to be beneficial but is it the sole reason for change? In some cases, yes. In other cases, no. We do know, and this is the paper that I was alluding to, where Dr. Mili Motro from Boston Orthodontic Department actually quantified that, and he found 2.35% volumetric increase, and his patient base was 8 years old to 22 years old. Now, I use different techniques for the 8 years old, like in the top picture, and the one on the left, it was the kids, you know, that were between those ages. And then for the older kids, the 22-year-olds, he used implants. But what he found is consistent, that for every millimeter of transverse width, you're going to get the same volumetric change. And so that's great on one aspect, but, and so that kind of leads to the thought process of doing skeletal surgeries for this process. And, but if you solely do that, now you don't have the cranial changes because you separated the maxilla from all other structures. So therefore you'll get improvement nasally, but you won't see a lot of the cranial changes. And it isn't just transversely. Again, it must be volume change because you need to alter oral volume as well as looking into maxilla and then being able to quantify that. So that's where the pharyngometry, rhinometry is useful in pediatric OSA, and now is being recognized with the physicians as very simple tools, non-invasive, to be able to determine whether or not people have been normalized. And so this is a tool that I've been using for over 20 years on adults and kids to try to find norms and have these kinds of understandings. So besides this kind of documentation, there's also cognitive behavior therapy that we use for adults and we need for children as well. In other words, good sleep hygiene and putting all of these things together, inclusive of good diet, supplementation, and you know, maintenance of airway. So it is a comprehensive plan that should be, and that's for the family. It's very difficult for parents to be doing something different than they ask their children to do. It's really a situation where you've got to get the whole family together and support in that way. So development and simplified pediatric obstructive sleep apnea screening tools. The American Academy of Craniofacial Pain is currently involved in a research project. I'm heading with Dr. Judith Owens from Harvard and Boston Children's Sleep, and Dr. Rakesh Bhattacharjee here in San Diego, who's the head of Children's Hospital Sleep Program. And we have a screening tool that we want to validate for this purpose, and for the physicians to refer to dentists for these kinds of therapies that Ed's going to share with you, and also for the therapies that I was just speaking of. And we can use this also for dentists to refer back. So screening tools are going to be very important for us, and to review our role, the dentist, in this process. And because we know the frequency is great, and we're not just talking about kids with OSA, we're talking about kids that have sleep breathing disorders. So even children like the one I just showed you, who was severe, you know, even after therapy, and that's where surgical cases for children may not be, and also part of our study is going to try to separate the kids that actually need surgery from the ones that don't, and look at other therapies as well. So, you know, so they talk about maxillary expansion, but there's much more to it. You have to really think in 3 dimensions, and we have to also understand that myofunctional therapy is very important for children at whatever age. And nasal breathing and lip seal, as well as lip tone, are factors involved. And it must be done consistently throughout the day. Camacho et al. Evaluated 9 studies in adults and 2 studies in children that demonstrated that myofunctional therapy decreases AHI by approximately 50% in adults and 62% in children. So these are huge adjunct, but standalone, I feel insufficient. You have to look at all the parameters, and you have to understand, and that's where the value of having imaging can help you be able to discern, and some of the other tools that I've shared with you today, if you understand how to integrate. So pediatric obstructive sleep apnea is highly prevalent, and especially in our dental populations, because of the presentation of symptoms. This is a screening tool that we give to physicians that is distributed through our centers. So screening for adults with their signs and symptoms as opposed to screening for children with their signs and symptoms. So these are things that are both going to lead to comorbidities probably early in life. Hypertension, type 2, obesity, GERD, thyroid problems. These are all things, asthma, ADHD. These are all things that you're going to see in both populations. And don't be surprised if you see them very early in childhood. So the bedwetting, the daytime sleepiness, the headaches, the jaw pain, these are all comorbid, as well as the dental presentations, and certainly looking at tongue-tied, chapped lips, broken teeth, and all these kinds of things. I didn't speak much to the tongue tie, but that's one of the first screening tools we use. Catalau, 50% evaluation with the mouth open, the tongue lifting up. So prevalence rates are very high, OSA with malocclusion. So we should understand that that's one of the things we should be looking at. There's many studies on those relationships. And so malocclusion is one of our first things. So you want to screen your pediatric population, asking questions about whether they have bedwetting, dental crowding, speech, restless sleep, night terrors. The Epworth scale that we usually use for adults, supplanted perhaps with Bear's screening tool. This is produced by Judy Owens from Harvard. And this breaks up the questions depending on age, 2 to 5 as opposed to 6 to 12 as opposed to 13 to 18. There's the validated pediatric screening questionnaire, PSQ, and asking questions about snoring and other related components. Dentists and hygienists are going to see, patients more frequently than the physician. So we're at optimum to be able to screen, because the dental presentations are going to be all the things that we do dentistry for. Dentistry has lots of local therapies for systemic problems, is my belief. And I think if we understood how breathing contributes to that whole component, then we would be able to do what we set out to do, which is to have an approach that is strictly preventative. So we're asking you now to assume that everyone has a problem and then work backwards to rule out pathology, because in the dental population, that's a more likely situation. So collect data, find pathology, do your evaluations, but with the thought process to also be looking at the kinds of things that we spoke about, the mouth breathing, restless sleep, sleeping in odd positions, witnessed apneas, night terrors, mood changes, poor concentration, and all of the things that are going to point you in the direction of respiratory problems. And that's also headache, orofacial pain, and facial pain, jaw problems are all components. So if you look at prevalence rates and understand that the American Academy of Pediatrics 2012 practice guidelines state that pediatricians should be checking all children and adolescents. They state that all children and adolescents should be screened for snoring, and that a PSG should be performed in children/adults with snoring and symptoms and signs of obstructive sleep apnea. So if we have this kind of prevalence, and that is going to equate to, if you have 500 kids in your practice, you're going to have a significant number with these issues. And if you would like more information on that, I recently authored this book, came out a few months ago, on airway management, basically overviews all the things that we just spoke of. And so thank you. I appreciate your time for listening. And it's now time to listen to the expert. I'm very excited to hear Dr. Lipskis' presentation. Thank you.
All right, everybody see my screen here? All right, so we're going to start off with a little testimonial. I always have a zillion slides. I actually had to cut about 300 slides last night over what I thought I wanted to present, because obviously we've got an hour here to do this in. So, but we're gonna start off with this testimonial, because I think Steve's, towards the end there, he made a comment with children, assume there's a problem. And that is clearly the case in patient after patient that I see. The airways are just really bad. The symptoms, once you get into it, that parents don't understand or connected, are practically universal. Derek Mahoney from Sydney, Australia, an orthodontist, probably the busiest orthodontist on the planet, just recently completed his PhD, and he's publishing a study from that, around 2,000 patients between ages 7 and 9, and wasn't just looking at AHI, but he did full PSGs on all of these patients, and found that, I mean, a ridiculous number. I can't wait to read this paper. 93% of all those children between age 7 and 9, again, granted, that presented at an orthodontic office, so a little predisposition towards having some issues, but still 93% had sleep issues that were significant enough, in Derek's words, to merit treatment to address those issues. So interesting stuff. So I'm going to play this video, and we'll just listen to it.
My name is Micheline Welch, and I brought my daughter Rowan, who is 7, to see Dr. Ed sometime during the summer. Rowan was having trouble with sleeping. She's never slept a night through since she was born. She was breathing through her mouth. She was grinding her teeth at night and waking up many, many times, oftentimes sleepwalking and such. Always had swollen tonsils and congestion that didn't respond to anything. A friend recommended Dr. Ed and said her children had great results with the therapy here. So we brought Rowan in for an evaluation, and we're kind of shocked at the results. She had fluid trapped in her sinuses, which was consistent with us always seeing fluid in her ears at the doctor, but not necessarily with an infection. She also had tonsils so swollen that they almost touched when she said but she would test negative for strep. Never really got fully sick, but wasn't always entirely well. Dark circles under her eyes. So we decided after having an evaluation and talking with Dr. Ed that we were going to go ahead and start her with expanders. She's had them about a month. Her dark circles are almost completely gone. I noticed about a week ago that she is breathing with her nose at night, with her mouth closed. She is actually getting tired on her own. We were previously having to use melatonin to help her fall asleep at night because she could just not unwind. And right around 7, 8 o'clock, she starts getting heavy eyes now and says she's tired and ready to go to bed and is able to relax. We've also seen an improvement with her mood. She just looks healthier, like she's doing better. Probably about 2 weeks in, she started having a cough, but wasn't sick. We took her to the doctor twice just because we were concerned, and found that there was no fluid in her ears. And her tonsils were only mildly inflamed. No longer were they the size of walnuts, red and angry looking. So we felt like maybe the expander had already started making enough of a difference that it helped drain her sinuses, and that led to the cough. But to hear she had no fluid in her ears and that her tonsils were only mildly inflamed, we haven't heard that in many years of taking her to the pediatrician. So we're very hopeful. This is just the beginning of her treatment, and we can actually already even see she has an open bite, and her open bite is even less pronounced. She's feeling the difference. So we're excited to see the changes already, and we're kind of shocked that this isn't being discussed with pediatricians and dentists and ear, nose, and throat specialists around the world, because this has made all the difference. It's non-invasive, it's non-surgical, and it's been impactful just in the first month. So we couldn't be happier.
So here's Rowan when she first came in, and I'm going to fly through the records on her. Clearly open bite, way deficient on tongue space. Her tongue space is just way short of what it needs to be. So just analysis. So her maxilla and mandible are both retrognathic, so we're going to end up addressing that. But because her nasal airway was so bad, other consequences. that's where we started. Whenever we take our records and we have to pull this mat out to orient how we want the kids to stand, you know that they're really struggling. These are the ADHD type patients that you know, just are distracted at the drop of a hat. So that's just our clue when we're looking at the records too. If we had to pull out the mat to get them to stand the right way, we know there's a bigger problem. You know, just a lot of crowding. The again, that tongue space is just way short. So nasal airway is bad. Actually, on her right side, in this slice, it didn't look like it was completely blocked off, but you can see how the sinuses are full of, you know, mucus, just loaded in there. So at that upper picture, the on the left side, at that level, it looks completely closed. So just big problems here. So her cervical vertebrae are displaced. We see that all the time. There's a drive that Steve talked about to open up your airway as much as possible. So when airways are bad, there's a change in posture that will take and try to find the most open oropharyngeal airway, and that's what's happening with Rowan here. So her minimum area was 6.3, and interestingly enough, not in the area of her tonsils, although it was really close to that in that area too. So this is her just 6 weeks later, after the mom came in and was just, you know, talking. She wanted to make a testimonial that you guys just heard. So I said, okay, let's see what happened. Obviously, in 6 weeks, you're not going to get huge changes, but you know, enough happened here where there was something that I wanted to really look at. So you can see it's got a quad helix in, which is one of my go-to appliances, and you can see that there's already, you know, significant lateral development. I don't do rapid palatal expansion. The rate on somebody her age is going to be about 0.5 millimeter a week of a constant slow force. I don't tear apart sutures, and you know, that's for another day. Limitation on an hour here. We're going to present as many cases as I can here and talk about them. Just understanding that I personally don't like to tear palates. So just again, she's actually slightly leveled out. As function becomes a little bit more normal, you get skeletal changes that are usually what you see is beyond what you're even trying to accomplish, because tongue posture's changed. She's more upright now. So you get a leveling that is initiated here, and all those things contribute towards that normalization. That even without a phonetic bite, although probably 80% of my patients get treated to a phonetic bite for all the reasons that Steve talked about. We don't always start off with that right away, but at some point, you know, that becomes part of the correction. So for Rowan, again, her nose is going to be slightly improving here. Condyles are a little bit back. So a lot of stuff going on. So here's a change in just her neck from the posture. If you look at that top left picture, if you look at C1, you can see the C1 significantly displaced to the left. The dark area next to C1, next to C2, the dens is much more obvious on the upper left picture to the left. This is the view from behind, and that change just in 6 weeks is way more centered. Again, it's because as your airway changes, posture changes. So this is her change when we look at that comparison. So even though it's still inadequate, I mean, to go from a minimum area of 6.3 to a minimum area of 93.1 in just, you know, a month is a pretty good improvement. So what are nasal airways supposed to look like? So this is Marianne Evans from Pennsylvania sent me this, showing just a peasant skull from before 1750 compared to what nasal airways look like today. So nasal airways have the potential to be much larger. She did admit that this was one of the largest ones she's ever seen, but I mean, as a rule, the nasal airways used to be much bigger, and all kinds of reasons, dietary and other things like that involved in that. So what are adequate nasal airways that we see today? So these are airways that aren't too bad. On the lower right there, you see this channeling effect. For people who don't have amazing nasal airways, what typically happens is one side is the preferred side that's better most of the time, and then depending on posture and especially during sleep, you get this change where one side becomes more open, the other side closes off a little bit. So that's typical. If you see a nasal airway that looks like that, don't assume that the one side's always bad, especially when you look at the soft tissue differential. Soft tissue on this patient's right side is worse than it is on the left, and that's typical for this channeling effect. So when I look at patients that have been coming in, even in the 30 years that I've been treating people this way, there's differences. So this is Ella. She presented, and she's almost 8 here and almost a failure to thrive. Teeth are finally coming in, but super crowded. You know, dark circles under her eyes, all those things going on. And this is the way she has to stand. If you actually have her try to become upright, lose that forward head posture, lose those changes in the cervical spine, and then later on lower down in the lumbar spine, she actually can't breathe well. She can't stand like that for more than 30 seconds without feeling compromised to breathe. Again, neck is affected. Airway in the velopharynx is really compromised for her. Again, maxilla is almost 5 millimeters back, mandible 7 millimeters back. Her face is growing longer because when you've got to breathe through your mouth and tongue posture is low, your teeth don't tend to hit as often, and it changes the way you grow. These are adaptations to survive. Basically, Steve mentioned that in a roundabout way, but basically when these patients present, again, assuming a problem, then what you see is the patient's best physiological adaptation to try to survive. And when you don't address the issues that led to that, you end up sometimes creating even worse problems. So the concept of assuming there's a problem and looking to see how you can fix that is the way to create a situation in which these kids can get healthier and the results can be more stable too. So again, all kinds of cants. When the cervical spine gets disoriented, sometimes you get all these changes that extend all the way through the cranium. And frankly, we get patients that come in and they're misdiagnosed with scoliosis, or there's a physical scoliosis that takes place, but it's part of this adaptation to try to find a way to open up the airway. And as the airways open up, then the scoliosis goes away. We get calls from physicians all the time going, so what did you do? Because we were about to treat this patient to address their scoliosis, and they came back 4 months later and the scoliosis is much less. And now we got them back 10 months later and the scoliosis is gone. Yeah, it's again, functional adaptations to try to survive. And breathing is a super high priority. Of all the priorities your brain has, the urgency for the next breath is way, way up there. Way more important to the brain than making sure that the cervical spine is aligned correctly. So again, super crowded in this case. The maxillary arch lateral dimension, 14 millimeters deficient. So all kinds of things to fix here. So typical other presentation, deep bite. So again, just showing you, how these patients present. So this, when you see this deep bite, class 2 div 2 with the upper incisors torqued back towards the tongue, their resting postures frequently with the tongue laterally placed, and their posterior teeth are actually biting on the tongue or touching the tongue really frequently. And so there's nothing opposing the eruption of the front teeth most of the time, so you get this deep bite developing. So that's all got to change for her. So this is how she has to stand in order to breathe. Same consequences as Ella. So these are things that need to be addressed. The other thing I'm seeing is an increase of incidence of impacted canines. Those are just the result of not enough space. The earlier you get to these problems, the less likely that's going to create issues. I've had patients come in, first time I've seen them is at 14, and they've already got erosion on those laterals. I've had some patients presented after seeing other practitioners, and they're going to lose their laterals at age 13 or 14 because there's no roots left. So these are things that are avoidable, and clearly we want to avoid them. Here's Joe again. Just the nasal airways, just really, really bad. These are sometimes I'll take and print out drawings and draw on them, hand them, and before I did that, I just scan them. conclude that. So that's why there's writing on here. So again, Joe, pre-treatment airways minimal. So these are all things we want to change and address. If you're not looking for these things, then you look at this kid and not think that there was a bad dental problem, and you probably put it off, which is what happens all the time. So again, just Joe in a 3D way here. So this is an important slide. We want to look at all these things as techniques that we can use. So the go-to thing that everybody talks about is expanding the palate, and that's important for, I mean, almost all these patients. I have very rarely not treated a case in the last 20 years where I've had an expander, and that's despite the fact that we use passive ligation, where it's been shown that you can develop the arches. When you develop the arches and all the force, whatever light force that there is at the alveolar ridges, you don't stress the mid-palatal suture, and so you don't get nasal airway developments. So if the nasal airways are inadequate, which I'm finding almost all the time, you got to expand the palate. If they've had rapid palatal expansion already, and you've got fusion of the bone across there, sometimes in the healing, in fact, often in the healing after rapid palatal expansion, you will get bony junctions across there, and then the maxilla and even palatine bones can function like they're one bone. They lose the flexibility that they're supposed to have. So number two, you can advance the maxilla, and that's important in almost all these cases too. Rarely finding someone who's not retrognathic. So you can develop the lower arch to accommodate the tongue. That's more lateral, but you can also reposition the mandible, and on children that's way easier. The phonetic bite will actually reposition them really well and open that up. So that's a huge thing. Like I said, 85% of my cases get treated to that. And then you can use dentofacial orthopedics. Works better on children. We'll talk about that right at the end of the day today. Because what I find is when you develop the maxillas, the mandibles come forward a lot on their own. So, and then just reducing inflammation. And Steve talked about these bottom things a little bit. You know, diet is huge. Diet in the U.S. is terrible. You know, the standard American diet is not named that for, you know, no reason. You take the initials, that's SAD, and it's a sad diet. It's the worst diet in the history of mankind. So, and unfortunately, a lot of the world is following us. So those are things that need to be changed. There's immune system responses based on a lot of things that we're doing. You know, the fact that we're antibacterial everything actually is a problem for immune system. Immune systems are meant to be stressed and strained. If you want to look at kids that don't have autoimmune disorders, that don't have big tonsils and adenoids, go to the farming communities where these kids are thrown in the dirt and they have animals around and stuff like that. Those are the ones that actually do really much better. So myofunctional therapy is huge. Again, as Steve said, it's a helpful thing, and it can make things stable. It can make things work. As a standalone procedure, it has some effect, but not, I mean, these kids today are really messed up. I at one point in time, once we had a CBCT, I started looking at my old cases going, okay, did I just miss all this stuff that is so really terrible today? And when you look at kids in the 80s and stuff like that, they weren't as bad as they had problems, but they weren't as bad as kids are today. This is something that needs to be evaluated. Myobrace, again, a useful tool. It gets you part of the way there. What we're finding is that in cases we use Myobrace, we still need to use some type of expansion on them. And if you talk to, you know, Myobrace people, that's a typical response. We find that we're between 70 and 80% putting in some kind of expander with Myobrace, even on young kids. So Buteyko breathing is huge, because Buteyko breathing makes physiological changes and actually decreases inflammation in your nose. Carbon dioxide in the correct concentrations, or there are techniques in Buteyko where you can increase the concentration of carbon dioxide in your nasal passages. Carbon dioxide is a great, I don't want to say decongester, but it's carbon dioxide works to prevent histamine release. So you don't even allow things to become inflamed when there's the carbon dioxide's present there. And then there's other integrative treatments with other healthcare providers. You know, those are not the usual things for 85 to 95% of your patients, but their patients present with all kinds of things, and sometimes you need help outside of what a dentist is allowed to do. So again, these are books that I recommend. The first two for patients, Wheat Belly and the Dental Diet. Dental Diet is a really poor name. It's a good overview book on how bad our diets are. And then Grain Brain, some patients can read that, but every one of us as healthcare providers should understand that. And Dr. Perlmutter has a bunch of follow-up books on that that are all really great too. If you like Grain Brain, don't end on that one. And the Wheat Belly book by Dr. Davis, there are some follow-ups on that. And the nice thing for patients on that, he's got some follow-up books that have some actually like cookbook type sections on them. So people can learn how to survive without wheat. It's a whole different discussion on the structure of wheat's changed. The fact that there's for the opioid receptors in your brain, there's part of the wheat molecule now that actually attaches to that, becoming more and more in effect addictive, and that's why wheat now is such a comfort food for people too. Crazy things. And of course, you know, the industry says that was unintentional. Yeah, right. So here's Ethan. Ethan, again, very similar to Ella, failure to thrive a little bit. He's a twin. I'm treating both of the kids, and Ethan's a little bit worse than the other one for a myriad of reasons. So Ethan's got a bunch of asymmetries. When you look at the alignment of his upper face and lower face, they're on different angles. His neck is not right below his head. One shoulder's high, one shoulder's low, all kinds of postural compensations here. So again, his maxilla is 9 millimeters back at age 7. That's crazy, but we're seeing it all the time. Mandible's back also. And again, his vertical height is short, and that's because there's different responses. So typically when you see bad nasal airways, I would say more often than not, the faces start to get longer. But sometimes you have these patients that have this just incredible clenching. When you look at the gonial angle on this drawing here, the gonial angle bone deposition is getting to be pretty significant at age 7. That's a response to clenching. So that can prevent eruption of the posteriors when the clenching's enough, and so the faces don't grow vertically the way they're supposed to. So again, just asymmetries all over the place here. And again, nasal airway is really closed off. And if you look at the top right picture, that oropharyngeal airway looks scary there. So when we look at the condyles, they're overseated, again, with clenching and stuff like that, typical. Lots and lots of crowding here, so needs all kinds of arch development. So when you look at that, minimum area is 2.7 millimeters, and kind of suspicious. And so when you see it from this angle, that gives you a better clue. So that in that minimum area, that when you see those indents like that, turned like that, that's usually tonsils. So when you look at that, there's his tonsils. So we sent him in for a PSG, didn't even want to try to do a metabite, which we do on a lot of patients. And his AHI was 44, scary. So because of the struggling and this kid's issues, we ended up, which is a rare thing for us, we ended up having his recommendation for tonsils out, tonsils were taken out. But as Steve said, the follow-up's got to be consistent with this. If you don't address this on patients like this, and his airway's bad everywhere. So the tonsils are just the result of this, in my opinion. But again, that was the place that was worse. We wanted to get him, you know, as healthy as we could, as fast as we could, and really worried about this kid actually not waking up. So again, he's got that cervical vertebral misalignment. Mariano Roccabato teaches some great courses on this. After taking this course from Mariano Roccabato, we started looking at cervical spine adjustments, and he teaches you to do that. Interestingly enough, with some training on there, dentists have license to correct C1, C2 when there's changes to the facial structure happening because of that. So I had a patient come in, had a posterior open bite on one side only, already been treated with orthodontics, and C2 was really poorly aligned using Dr. Roccabato's techniques, adjusted that. 2 minutes after the adjustment, patient said, don't have that open bite on that side. Both sides are hitting for the first time in my life. And that actually, we ended up treating her too, but that open bite never opened back up. And the alignment, because we started addressing airway issues, never relapsed for that. So again, just more stuff on that. So again, maxillary expansion causes dentofacial changes, especially in the nasal cavity. Consequently, the nose width enlarges, reducing nasal airflow resistance. So if you talk to Christian Gimeno, it's flow limitation and sleep fragmentation that are the things that actually make people sick. So if you don't address flow limitation, again, Steve showed that article on nasal airway patency, and nasal breathing 24/7 is probably the only valid endpoint for treating OSA. And I believe that wholeheartedly, because patients that don't have adequate nasal airways struggle with that all the time. So here's just a case from a while ago, just nasal expansion and 2.2 millimeter change in the width of the nasal airway, which from a flow standpoint is good. And we can get even more than that. That's all this patient really needed. So when you expand the way we do, though, you can't only expand on the upper arch. A lot of people think that you can't expand on the lower, and as long as you keep force levels light, we expand on the lower all the time, even on adults. So it's something to keep in mind. You don't want to expand the upper arch only to match the lower. You want to expand until two things happen. One, the nasal airway is adequate, and you have to look at inflammation there too, because there are patients that you start to expand, maybe you get 4 or 5 millimeters of structural skeletal expansion in the nasal airway. You take a CBCT and the soft tissue's filling it. So either they're eating a horrible diet that's super inflammatory, or they've got allergies and things like that. I mean, for years and years, I struggled with nasal breathing. As it turns out, I've got an allergy to down and feathers, and we were always sleeping on down pillows. So discovering things like that can be critical. I had, as a result of that, before we discovered that, I had nasal surgery that I probably never even needed. That's had a negative impact on my life because of the way it was done. Whole different story for another day. So again, bimaxillary expansion, that's a great treatment option, and it's usually where you have to start. But again, you saw that whole list of everything that we do. You have to fully evaluate these patients and address everything that you find that's not okay, and move them at least towards normal. The more you bring them towards normal, I mean, if somebody's got huge skeletal deficiencies, you may not get everything corrected, but you can make them functionally normal, and then over the course of their life, their face will continue to change. When function's normal, structure becomes normal. So here's Jaden, and we're going to go through as many cases as I can. We're going to try to get through everything here. That's my flaw, as Steve will know, is that I just want to load in so much information into your brains that I have trouble cutting slides. So anyway, so Jaden presented with clear signs of sleep apnea, class 3 skeletal pattern. You see the lower incisors are already getting in front of the upper ones there. So again, just evaluating him and looking at that, his maxilla is behind, mandible's already forward. Condyles are actually a little bit back, not too bad compared to some we see, but there's a lot of flattening here that you see on those AP views that is not normal, even on the lateral views. So concern there. Nasal airway, again, not the worst I've seen. The oropharyngeal airway, minimum area is 88. So again, it's not about just the dimension of the airway, it's about collapse. So what's the muscle tone there? What's happening at night? So because of the symptoms, because of witnessed apneas, we send them in for, we actually did a Byte sleep study. So apnea-hypopnea index was 17.8. Unfortunately, we don't have with this an EEG, so we couldn't look at sleep fragmentation. But fortunately, we've got in our back pocket Deepak Shirsava, who will read these for us. A lot of physicians, don't like to read HSTs. They want you to send to their sleep center, so nice to have someone that will. So again, RDI of 23.3, AHI of 17.8, and his recommendations included orthopedic, orthodontic therapy. So that gave us the go-ahead to not only treat this kid, which we were going to do anyway, but actually to send to medical insurance for this. we get a lot of coverage for our medical insurance, even when there's not, PSD, because we can demonstrate skeletal significant changes from normal. Some of the codes for medical insurance are maxillary hypoplasia, discrepancy of the mandibular position to the cranial base. There's reasons that we can submit when the abnormalities are significant enough, and so we're pretty. I mean, there's no perfect way. I've had insurance companies that tell me, we've looked at what you did. You submitted some other cases, at our request. So it looks like the treatment is going to be a great treatment, but it's just not covered. So it just, insurance is still insurance. So here's where we started off with Jaden, just upper quad helix again, lower E appliance. So even though he's class 3 and the mandible is developed, both arches needed lateral development to fit his tongue. Class 3 patients tend to have big tongues. So we sent him in after mom was reporting no more issues that she could tell for another sleep study, and still had an AHI of 1.6. So technically still an apneic as a child, but from 17.6 to that, just with that and some myofunctional therapy, going hands pretty good. So he still needs some upper arch forward development. We removed his lower E, expanded, put him in composite build to a phonetic posture. So again, treating that phonetic bite, and that got his AHI to 0 before we even finished treatment. It also got him off his Adderall and is no longer considered to have ADHD. So again, you can use light force spring expanders on the lower arch to develop that arch dimension. And we do that all the time. So again, light forces needed to develop this oral volume. And that's, I mean, the conversation that I have with patients and their parents when they come in, I mean, so I'll tell them, well, I'm just pulling these numbers out of thin air just to make things, but basically you've got a size, your son or your daughter has a size 7 tongue trying to live in a size 5 space. And when it can't fit in there correctly, it's either going to be forward, it's either going to be low and forward, or it's going to be dropping back and blocking the airway. So you have to create the space that you need to fit these tongues. So here's Matt. Matt was a swimmer who was struggling. When we looked at him, his oropharyngeal airway, again, this is 2D, but back then before we had our CBCT, but really a pretty closed down airway. There's studies showing that this view is still valid in determining, that it's got some validity for that. And look at that military neck. I mean, necks straight up and down. Necks are not supposed to be straight up and down. His lip competency is a little bit compromised. His face is growing longer. That mandibular plane angle is a little bit steep. Some crowding here. Again, those canines really have no place to go. Lower canines are starting to tip, and they're significantly lower than the first premolars. First premolars are not supposed to erupt ahead of them, and it's going to be kind of a race there. So I don't use a lot of Hyraxes, but on Matt I did. And again, it's about the rate of expansion. Whatever expander you're comfortable with, you can use, and understanding that the rate is more important than anything else, and then making sure that tongue posture and function is as normal as you can get. So one nice thing about a Hyrax is it typically doesn't cover the spot, so tongues can still get up there, and you have to work really hard. The quad helixes, W arches, and things like that get in the way less, especially if you don't cover the spot, again, with the wires that goes in that anterior part. So used an E expander on him on the lower arch, because, again, not adequate room for that. In retrospect now, he was able to function normally enough, but probably could have benefited from a tongue release. So this is him, expanded, plenty of room for all the teeth to come in. Arches developed, got a lingual holding arch there, holding that again, possibly because of that tongue. That's not a typical retainer for me, unless I'm planning on doing some phase 2 treatment right away, and on him, that wasn't the case. So, but you can see the difference in that oropharyngeal airway. No longer has poor sleep. His pre-treatment AHI was apneic, in the 5s, and his post-treatment AHI was 0. And his swimming improved immensely too. So bigger airways never hurt for that kind of thing. So 3 years post-treatment, I won the NCSA Junior Championships in the 100 freestyle. So here's Sophie. Again, Sophie's got that anterior tongue thrust, a little flaring there. So that's a concern because without changing that, the stability of anything that we do is going to be compromised. So that's a big thing for her. Again, typical of what we see, a lot like Matt's airway, really closed down. So again, crowding. She had with an AHI in the 3s there. So again, pretty similar to, we did some degainer technique. We'll talk about that later on here today. But so she wasn't just expanded, her maxillary anterior skeletal development was done a little bit. And again, a lower E arch. And you can see the differential there, that lower airway opened up a lot. AHI is now 0. So is your tongue in the right spot? We've been kind of mentioning that. So tongues are huge. So interestingly enough, for a lot of patients, just by expanding and creating the space, the tongue posture changes. So not always, which is why you need the myofunctional therapy, and obviously evaluation for ties and things like that are critical. So nasal breathing tongue posture, mouth breathing tongue posture is just low. And there's not time to really get into this here today, but the tongue posture, when it's low, you're automatically going to end up with a smaller maxilla. The tongue is the template for the growth of the maxilla, and when it's not up there, maxillas grow deficiently. So again, different tongue postures and their malocclusions. So again, number 1's ideal. We go all the way to number 5. The lower the tongue posture, the more there's a tendency for class 3 growth patterns and for really small maxillas. I'm seeing way more class 3s statistically. We went through our cases and way more class 3s now, and not all of them are excess mandibular growth. A lot of them are just class 3s because the maxilla is so small. So I couldn't find one for a lateral view, so I just drew these. And again, different malocclusions reflected by different tongue postures. So obviously class 1, nice tongue filling up the whole palate. Class 2, div 1, tongue's a little bit lower, tends to be up against the teeth instead of up against the just the palate missing the teeth. Class 2, div 2 is a little bit lower, just like Charlotte that we looked at, the second patient, in just the observations over the last 30 years of treatment, with that deep bite and the detorquing of the upper centrals. So that posture is lower. And then class 3s have the lowest tongue posture. So again, we talked about tongue ties. So you got to look at that. If you have a patient like this, the younger that this gets fixed, the easier it is. We have infants coming in that are just weeks old. We used to do tongue tie releases in our office, and now we've got Dr. Milt Gavelis, who's one of the authorities in the country on that, and so we send them all out to him. But it's a critical observational thing. Again, is there, when the maxilla is not developed, if you look at the way the teeth overlap and the tongue can't fit into the palate. So if you're looking at patients and when their upper and lower teeth line up so that they match, there's still not room for the tongue, you still need to do arch development. Again, myofunctional therapy increases stability. That's the thing that we see in orthodontic cases all over the planet now, really. The more people treat the way that we treat in the US, the less stable cases have become. So myofunctional therapy is a way to make sure that the cases stay stable and just normalizing function. Normal function seems to lead to stable cases, and that's what we're finding. I know Steve doesn't like retainers. Steve he's not a huge fan of doing ortho. He's been forced to do it, for the betterment of his patients. So, but this is a huge tool to make sure that things stay stable. The other thing to look at too, again, and Steve broached this too, when we're looking at AHI, it's such a small part of the picture, and again, not the problem. So upper airway resistance, sleep fragmentation, flow limitation, respiratory disturbance index. All those things are things that are really more important things to make sure change with our treatment. We don't change sleep fragmentation and flow limitation, we've blown it. That patient is never going to be okay. So there's neurocognitive and behavioral consequences to poor airways and fragmented sleep. So we've got these kids that just are having different responses. So you have these kids that get distracted, kids that are tired, kids that act out. These are all things that we want to make sure are part of our diagnosis. You know, we've got to understand what's going on with these patients and understand how to help that. So there's all kinds of articles on cognitive dysfunction, and the article that really has a big impact on our patients and the parents is this one from Johns Hopkins, where children with OSA and actually any sleep disturbance that fragments REM sleep had lower mean IQ test scores than children without OSA. And it was significant, 16 points lower. So that's a huge thing. The full article is here. And what she says, we find that these deficits in IQ, cognitive function, can permanently alter the trajectory of development child's ultimate cognitive potential. So if we don't address these things in time, and I'll get to what in time is in a second, then this fragmenting of REM sleep, the decrease in new neural pathway formation, along with prefrontal cortex delayed development, at least, or never fully being developed, are significant. And again, getting these corrections too late doesn't allow for fully getting these children to what their true cognitive potential should be. So this is a graph from Harvard. And basically, higher cognitive function is the red curve. What we're finding is somewhere around, for the average patient, 8 seems to be about the end where there's still enough space under this accelerated growth curve to get things back. Now, for some females, because of their earlier development, you actually need to jump in earlier. So with females, I'm trying to jump in there by age 7. That's an interesting time because that's the time that the Orthodontic Society says that's when we should first look at these patients. And when we're looking at them at that age, that's kind of too late, and they don't really want to treat at that age either. So we need to change that paradigm because there's so many things that negatively impact lives forever if we don't jump in. So again, showing that there's evidence from age 2 onwards that there's smaller gray matter volumes with these sleep disturbances. So again, the earlier you treat, the less there is to fix, and the better the results and more stable the results can be. So again, we're going to talk about, advancing the maxilla. This is probably the most difficult thing for most doctors to get in and understand how to do. So, and you can advance a point just using light forces. And there's a difference depending on where the problem is. We'll get that in a minute. So again, different types of forward traction pads. There's all the top 2 here have a chin pad. Whenever you have a chin pad, there's a tendency to make the faces get longer. The chin gets rotated down and back. Sometimes if you've got a TMJ problem, it can exacerbate that. So Dwayne Grummons developed, and it's not this one, but developed a reverse traction appliance that doesn't have a chin pad, but it's got zygomatic pads. So the zygomatic arches are things that actually develop when we're advancing the maxilla. So I kind of view this as standing on a table while you're trying to lift it. If you're holding back part of what you want to have come forward, how successful is that? And you can change. You can change. You can get the central part of the maxilla, the alveolar ridges to come forward, but the facial development, in my opinion, and Dwayne and I have talked about this many a time, is problematic. So I actually like these tandem bows, and we don't use them exactly as shown here, but it's an appliance that the musculature of the lower arch seems to carry this, and you're pitting you're pulling the maxilla forward based on that, and we've had huge success even in adults with this. So here's Brady. Brady came in. He's class 3. He's already had a diagnosis of ADHD. He's on Ritalin. PSG showed him have significant ADHD. RDI was 31.2. Sleep is fragmented. 100 arousals overnight. So again, he's got an eye issue that is actually got addressed surgically during our treatment, so that's better. Again, just crowded. Again, maxilla is deficient, mandibles forward, so class 3 pattern. Dentally, your teeth try to make it match, but skeletally, things are getting way off here. So when you see on this lateral view that the tongue can't be up in the palate, so our patient's instructions are to put your tongue up in the roof of your mouth, close your lips, and bite together for these images. When the tongue can't stay up there for even the 8 to 20 seconds that we use, depending on which scan we're going to use, you know that the patient's really struggling to breathe through their nose, because when you can't breathe through your nose, your brain doesn't want your tongue up in blocking that oral airway. And these are the patients that, because of the protective mechanisms involved there, have these really strong gag reflexes too. So a strong gag reflex, although not always indicative of a poor nasal airway, is certainly a sign that there probably is one. So again, jaw joints a little bit back. So where he's got his minimum area, though, is up high in the velopharynx, and PNS is pretty far back. So just advancing the anterior maxilla and leaving the posterior maxilla back there is not a good idea for this patient. So for him, we put him in a tandem bow. Now, he's a patient that I wanted a phonetic bite, because the phonetic bite by itself is going to open up the airway. And there's studies, some done by Steve, showing that the phonetic bite opens up airways anywhere from minimum of 16%, and I've seen studies where it's up in the 30s. And even more important than that is it's been shown to reduce airway collapse at night, which is huge. So here's delivering that fixed tandem bow, and we have that sibilant Byte registration that we took. So there again, this kid's also got a quad helix. The lower component here, you can actually get slight expansion if you need with that. But this one is tended just to hold, and again, on a lot of class 3 patients, that's what we do. So what I'll do is I'll take and use that phonetic Byte registration, the blue Byte, and cut out a template so that I can seat it over the patient's teeth and build up to the phonetic Byte. And again, using Steve's protocols, we'll do MNRT, so motor nerve reflex testing, to make sure that this bite is where we want it to be. And so this is a typical thing that I do. And we use regular composite, we not like Triad or anything like that, because it's going to be in there for a while. We don't want the wear on this. We want it to hold in that position. The other plus with this is you get that 3-dimensional change, the pitch, yaw, and roll, because you got the phonetic position. And it's in there as a permanent thing fixed with these kids that have, the distractions from ADHD-like symptoms. Again, sleep disturbances are the leading cause of what has been diagnosed as ADHD. It's not the only cause, but I mean, it's significant. So when we find patients with that, and they have these airway issues anyway, that's certainly what we want to address. So again, not a lot of time in here to teach you how to do a lot of things, but one thing, if you're going to use these tandem bows, this is the way you get the bows from the labs. We don't want that because that wedges the lips apart. So I'll take, if it comes from the lab like that, I'll just bend the hooks down. And if you look at the top row here, you can see how when it comes from the lab, it forces those lips to stay apart all night long. If you bend that so that the elastics are at the same level as the wire, it gives the patient a chance to keep their lips together. And I like to have that bow just far forward enough so that if the patient has to tape their lips, they can do that. This one is not, but he can actually tape his lips right over that, right down the middle if he needs to. So again, here's Brady again. So his we had to bend that down. Now, for young kids, I like the forces, total forces, somewhere between 400 to 500 grams. So 200 to 250 grams per side. On adults, that really goes to 500 to 600 grams. And force levels make a difference. You got to measure this. I have people that come to me and they go, yeah, it's not working the way that it seems to work for you. And I go, are you measuring force levels? No, I just used the elastics that the lab sent me. I go, so how do you know those are even close? If they're not enough force, you're going to be actually moving teeth and not moving bone. If they're too much force, you're going to engender an inflammatory response at the sutures. You're going to compress some of these sutures and you're going to stop it and it's going to hurt. So force levels make a big difference. Again, a lot of research showing this. So again, the forward movement of the maxilla was increased and it found that that was successful in this traction appliance pool. But the treatment changes remain significant even at the end of 4 years. So, and a huge part of that, again, is making sure function is normal. The more you make function normal, you normalize everything. And then if nasal breathing is there, tongue posture is there, lip seal is there, those are all things that are critical. Class 3 patients are the patients that are going to tend to relapse the most if you don't normalize all these things. And again, if you want to frighten these patients, tell them, so if you get relapse and you're now 17 or 18, because we don't want to treat class 3s until the mandible is done growing in boys, that's frequently 17 and 18. There's a way to evaluate that I'm not going to get into today. But surgery is then a possibility. So nobody wants surgery. Parents don't want it. So again, it's motivation really just to make sure that they don't eat like crap, to take a bad word there, because that can cause the nasal airway to become inflamed. If the nasal airway becomes inflamed and blocked, tongue posture is going to get low, and all these negative things are going to come back. Tongue posture not being up there, the cheek muscles, the lip muscles, they all have a tendency to create an inward force, and that's a perfect orthodontic force. It's light enough so you don't get an inflammatory response, and yet alveolar ridges remodel as teeth change, and the maxilla gets narrow. When the maxilla gets narrow again, structurally, the nasal airway gets narrow again. So again, function is a huge thing. Again, just showing, studies that show that the maxilla continues to grow forward after treatment if they still have growth left in it, if they're young enough. And the improved nasal, pharyngeal, and oropharyngeal airway dimensions, initially, that was maintained at long-term follow-up. So huge things here. So here's Brady again. We brought his nasal maxillary complex forward 5 millimeters, tandem bow, moved back in 9 of 17. And new polysomnogram shows the AHI at 0.6, 10 arousal events all night, no longer on Ritalin. So yeah, you used to have 100 arousals. And we're finishing him up. So again, maxilla is out in front of the man. Interestingly enough, because of his condyle and stuff like that, mandible came forward too, which is expected. He's going to end up not with a small lower face, which is typical for these genetically predisposed to class 3 growth patterns. But his airway is really good now, and he's not struggling anymore. So again, we got a few other patients here. So this is Miles. Try to finish this up pretty quickly. So Miles again presented with sleep disturbances, really bad. Nasal airway was terrible, and a little bit of inflammation there, but not that much. Oropharyngeal airway is bad too. Condyles are up and back. And so his minimum area is 38.2. So in these consults, we show this image and I go, so what we don't want to see in this color representation of the oropharyngeal airway is anything that's red or black. A lot of these patients, that's all they have, or some don't even have any red, it's all black. So when we analyzed him, his maxilla is 7.2 back, his mandible is 11.3 back. So you can't bring both those forward at the same time without surgery. And he doesn't need surgery, we can correct that. So this is him with his bow in with the elastics. You can see that his hooks are down and forward, so that those elastics have a shot at being that. You have to rebend the bow to swing it up and bring it out forward there. You still have to have it leave the lips at the point of lip contact when it's a relaxed lip contact. And he's been a mouth breather so long that you know, his lips are really chapped and stuff like that. So Miles at 7 months. So you can see that maxillas come way forward. Again, when you have patients where the maxilla and mandible are deficient, you have to tell the patients, we can't bring these both out at the same time, parents too. So this, you're going to create this overjet that may look a little goofy, and lip competence may be difficult at this point in time. We're going to bring the mandible forward too, but we got to get the maxilla out where it needs to be. Now this is where the Grummons face mask comes in handy, because once the maxilla is already forward, and I'm not trying to bring it forward, I just don't want any headgear effect from any of my class 2 mechanics. Then at nighttime, and nighttime only, instead of the 12 hours a day that they have to wear this appliance normally. So if just while they're sleeping, they wear a Grummons face mask with the zygomatic pads, then the mandible can come forward without making the maxilla go back at all. And that's a critical thing for a lot of patients. So again, you can see the difference here. So laterals were in crossbite, now they're out in front. And even though the mandible actually advanced on him 3 millimeters, which is great. It means I have to bring it forward a little bit less. You know, we still got those laterals, which are really lingually torqued, you know, still out in front. And again, with this, I'm expanding a little bit, but once we stop the forward traction here, we're going to expand him more, create more space. His nasal airway got a little bit better, which allowed for tongue posture to change, but that's all going to get changed for him. So here's Charles. Charles is age 7, already in class 3, and his physiology tried to maintain that, you know, not an anterior crossbite for a while, which is part of why the lower incisors are torqued back so much. So again, just showing the overjet and everything. So again, whenever you see that little pad out there, that means that these kids' concentration was really bad. That's not, you know, if it's a 3 or 4 year old, no big deal, you know, you do that for all of them. But when they're 7 or 8 and we have to pull that out, you know that there's a problem. So again, nasal airway is bad, got a little bit of a deviated septum. That oropharyngeal airway at this view doesn't look that bad. Again, nose a little further back, nowhere it's good. Condyle, so a lot of people don't think that the class 3 patients have TMJ problems. They have TMJ problems just like anybody else. Anybody can have it. So C1, C2, a little bit displaced to the right, a little bit rotated. So that oropharyngeal airway is not that bad, but minimum area way down low at the bottom of his chin, right at the epiglottis, still 91. And again, maxilla is way back. Maxilla 7.8 back, mandible is normal according to this. So we started in forward traction. Again, quad helix as an expander in there. And 6 months, he's out of the crossbite. We're still going to go a little bit more on him yet. So we've got a degainer technique. I got a few minutes left here. We'll just go through this real quickly. So this is just an advancing A point type thing in a mixed dentition. And the simple concept is you get up to a rectangular wire, still have an expander in there, and that expander acts as stabilization to not allow the 6s to go back. The unerupted 7s, second molars, they help with that. You don't want more than 50 grams of compressive force per side, so you got to measure that too. So his AHI went down to 0 post-treatment. So I got 2 minutes here to go through class 2. This is the last thing I'm presenting here today. So there's articles by Voudouris and Kuftenek that actually explain how this works better than anything else. We'll just go through this really quickly. So there's bone that develops in the posterior part of the fossa. At the anterior part of the fossa, bone goes away, and at the bottom and front of the articular eminence, you grow new bone. And it's just by maintaining a forward posture as much as possible, but the cellular activity seems to need 10 hours of forward posture steadily in order to make that happen. So fixed appliances seem to work better than the removable ones. If you have cooperative patients, removable ones like twin blocks and things like that can also work. The 3 growth stimuli that work together, displacement, you get this viscoelastic tissue, there's remodeling. Even the change in synovial fluid allow those changes to take place more than anything else. And this is just a just grab the case. So again, deep bite, class 2, div 2. These are patients that you don't like to treat late. This was kind of late for him. So when you look at his chin at the end of this, it's a compromise because maxilla is a little bit back on him, not way back. Mandible is not as back as the teeth are back. So, and it's difficult to get the lower incisor bone facial to it to develop much. So the finished, that fold under the lower lip is a little bit more. So this is the day the Mara was removed. So again, we're going to try to do some vertical changes with him, and if we can get that deep bite a little bit less, then we should be able to get it better. But even with that, you can see how the lower incisors got detorqued, trying to maximize how much forward the mandible came. So that's my presentation for the day. So we can open this up for questions now for either Steve or me. Pull up my webcam.
Great. Thank you. I have a few questions here, and then as more roll in, I'll let you know. So let me go ahead and just pull these up on the screen so that you can see them. Okay. Are you able to see those questions, sir?
I can see them. So will pediatric OSA lead to future cardiac disease? Yeah, pediatric, and Steve can answer this too. So pediatric OSA seems to lead to adult OSA when it's not addressed. And so, yeah, OSA in general leads to that. Won't the tandem also open the bite through eruption of lower molars and adversely rotate the lower jaw back as well? It can if you don't control it the right way. I can use a tandem bow and get straightforward development of the maxilla. You have to anchor whatever tooth that you've got the bands on, or an even better technique is you take and use a removable lower appliance to a phonetic bite, and you put the tubes for the bow on the appliance. So that doesn't do that. So you're getting them in a phonetic bite. You have to have great retention for that appliance, although the force levels aren't that super high. But if the retention isn't good, you can displace that. And when that gets displaced while the patient's asleep, that's not a good thing. But so if you just take and you have tubes on the lower molars, let's say, and you don't have anything stabilizing those, yeah, you'll kick those back and open up the vertical. Most forward pull appliances, just in the directions the elastics pull, bring the maxilla forward and down. So today, with and sometimes you can't avoid that. So today, if that's a problem, we talk to the patients beforehand and tell them, okay, once we've got your maxilla forward, which is the hard part, if the vertical is excessive, we can place TADs and intrude the entire maxillary arch and correct the vertical. So it's more complex, but lip competence is a huge thing. Sometimes you need to increase the posterior vertical, but not increase the anterior vertical. So there's ways, again, with TADs in the anterior, holding it either with an appliance in the posterior or erupting just the molars first, and then using those molars as the fulcrum of a teeter-totter, if you think of it that way. TADs in the front and arch wires in place. If I've got arch wires tied to the TADs so that it makes it impossible, and these TADs are on the upper arch above the incisors and on the lower arch below them, that doesn't allow those anterior teeth to erupt because TADs are basically immovable structures. So when you take and you put vertical elastics, I don't care if you go TAD to TAD. I don't usually go TAD to TAD because you go across the gingiva a lot when you do it. But because these teeth can't vertically erupt with those TADs in place, you just do vertical elastics, arch wire to arch wire, and that rotates that up using the erupted molars as a fulcrum. So the erupted molars tend to get slightly intruded with that. But the nice thing is the condyles, because they're on the other side of this fulcrum, they tend to move down. So the thing that you have to look at the end is not the vertical at the condyles, it's because you put them in a phonetic bite, usually they can't, but you want to make sure that they're not displaced posteriorly at all. And usually in that rotation, there's a tendency for the mandible to come forward. So I worry about that, but I've never actually had to fix that.
May I just
Yeah.
add, Ed? So whatever people's understanding of what a phonetic mandibular position is, we've alluded to the three-dimensional correction that gives tonus to the airway and reduces collapse. But there's an orthopedic component that Ed's speaking to. So if we have this three-dimensional cant, and then you try to bring these forces, then they're not going to be always in the direction that you're hoping them to be. And that's why if you start from a three-dimensional orthopedic position, which is the phonetic, and then apply those forces, then it'll be in a more parallel way, and it'll probably minimize the outcomes that you might be seeing.
Right.
Is that what you'd say, Ed?
That's exactly correct. The other thing you have to look at, so there's all kinds of influences on things. If you take and you put the exact same forces on the left side and the right side, they don't always come forward exactly the same way because of other influences. You know, sleep posture, you know, all kinds of weird things. So sometimes you have to adjust. So in that range, say I've got the right sides coming forward more than the left. The next time the patient comes in, you note that, because my staff has me just trained, and if I haven't looked at the patient's both skeletal midline and dental midline during an appointment, I get what's called a de novo, where it's from NCIS, where Gibbs just whacks him in the back of the head, like, hey, you forgot to do this, do this. So that is a critical thing to look at. And then you can just adjust the elastic forces so that whatever, if the right side's coming forward too much and my range is 200 to 250, so the right side's going to be at 200 grams, the left side's going to be at 250 grams. And that's going to balance that out, because I'm just trying to counteract something that is happening within the patient, whether it's muscular, whether it's bone density, whether it's, you know, sutures just are not, because where you get the growth changes with this is at the sutures. Well, are the sutures symmetrically aligned? No, I mean, there's differences in all of that. So, you know, so that's that. So the second part, meaning like 1 millimeter a month forward. So at the beginning, the first month, you'll probably get less than that. With kids in this age range that we're talking about now, 6 to, and even younger than 6, but up to about, you know, 14 or 15, you get probably at the end of 7 months, you get about 7 millimeters. So it ends up being about 1 millimeter a month. We do this on adults, and you get less for long. Like the first 3 months on an adult can be frustrating, and you have to tell them, because in the first 3 months on an adult, you'll probably see what looks like nothing. And then you get these sutures changed enough to make them more childlike. So sutures in adults tend to get really, really complex. They never really fuse. When they fuse, that's actually pathologic, but you end up with places where the bone winds around the other bone, and when you start to try to change that suture and move them apart, you end up with bone running into bone. And you have to keep the force levels really light enough so that you don't engender an inflammatory response with that. You engender an osteoclastic response. So what do you need to get osteoclasts to activate? You have to have a blood flow there to produce these osteoclasts. So as long as you keep the blood flow intact, over time in these adult patients, you remodel, and this osteoclastic activity gets rid of this bone that's interfering with the sutures moving apart. And in adults, you know, it can take 3 or 4 months because there's so many sutures involved. But at that point in time, the sutures become much more, I guess, lack of a better word, childlike, where these interferences are gone, and then they respond very much like children do. So, I mean, you have to pay attention to how far you need to go, and you have to pay attention to how far functionally you need to go. Because if you have a patient that's 11 millimeters back on the maxilla, I mean, we can get them 11 millimeters forward, but do they need that? And sometimes, you know, it's, you know, how long can you keep somebody in a Tanabeau, or any of these face masks where you know it's 12 hours a day. Some people advocate 24. That I find that actually makes it slow down. You get more inflammation. So 12 hours a day seems to be good, but people get burned out on that. You kids tend to go longer, but adults, you know, it's a difficult thing to say. But once your oropharyngeal airway is adequate, and you got lateral development the way that you need to, and their face looks good, do you need to keep going? I mean, I don't. I look at them, I go, so you look way better than you ever looked before. You're pretty good looking, and that's one clue for, are we treating them correctly? You know, I see patients treated with orthodontics all the time that actually look worse when they're done. Their teeth look straight, but their faces are worse. If you treat a case and their face looks worse when you're done, then you blew it. So anyway, that's my thoughts on that. Any other questions? That's what I'm seeing.
Yeah, just two more real quick ones. So if you mind just knocking these out real quick, then we'll conclude the session.
So what's that? I have no idea. My staff didn't create that. They found it somewhere online. I can try to get that to Justin or somebody, you know, and see if I can get that information for you. I have no idea. So many things happen in my office for the better that I have no idea that they're going to be happening, and that's a beautiful thing. So where can I find training centers that specialize in OSA? The guy whose picture's next to me, that's the best guy on the planet to go see to learn about OSA. I mean, the knowledge packed in that guy's brain and the understanding of all the different ways that people treat, the pluses and minuses of that. I mean, I would start with Steve, hands down. What's the criteria for referring a patient to an ENT? It's multiple criteria. So you know, if I have a child that's never had rapid palatal expansion, you know, we're going to try to do that. I mean, so the Ethan that we looked at, where the, you know, HI was 41, you know, I forget what his RDI was, you know, and what his REM fragmentation was, but this kid was, you know, scary from that standpoint of that. So we don't know. I mean, it's really rare that I send out somebody to get tonsils out because they shrink like crazy when you normalize function. You get that nitric oxide coming in from the nose, antimicrobial effects of that, and along with the difference in, you know, capillary permeability, better oxygenation, all the, you know, kids just get healthier for multiple reasons with that. There's 30 functions now, if you go through the literature, 30 functions that happen physiologically that are positive for a patient when they breathe through their nose, at least 30 that have been documented, that don't happen at all when you breathe through your mouth. So, so criteria for referring a patient to an ENT, Steve refers probably more than I do. I have adults who have had rapid palatal expansion, and we try to expand them and nothing happens. So it's either a surgical expansion or it's, you know, if you look at them and you go, okay, an ENT can go in there and get rid of these swell bodies, get rid of this concha bullosa, whatever's going on in their nose, and probably give you a nasal airway that's functionally adequate, especially if we go through Buteyko breathing, where we understand that most people are hyperventilating these days. And if you slow down the respiratory rate, you don't need as large a nasal airway as you do because of the increased, you know, collapse of the nasal airway, the negative pressures. So that ends up being there, but there's still patients that you have to refer. Again, more adults, people who have had rapid palatal expansion, people who have, like, you know, adenoids and tonsils that are so enlarged that they're fun. I had a patient in that we sent for adenoids because the airway through that area was under 1 for millimeter squared. So I mean, that's scary. That's you worry that kid's going to get a cold and die. So that's where I'm at. What do you think, Steve?
Yeah, there's a huge variance from ENTs as to when they might initiate surgery of this kind. I was asked to present to an ENT symposium in Boston last year, the minimally invasive program, and just listening to the different ENTs as to when, because this is a very specialized group. They were, the top of the people who were thinking about reconstruction. As we all know, there's a huge variance in ENTs. And even in this select group, I was surprised that they were asking the presenter, or the presenter was asking the audience, ENTs, well, what are you guys comfortable doing? And there's a lot of confusion. People are talking about different things. Then it turned around from the audience asking the presenter, well, when do you feel comfortable, intervening? And he says, well, I do surgeries as young as 3 for these kinds of things. And you could see it really kind of took the audience back a bit, because even in this group, they were thinking you had to be, a teenager or something in order to get.
Was that Peter Catalano presenting?
Peter Catalano. Yeah. So I was. I just wanted to attend because the walkers were presenting, and I thought, great, this is a great opportunity for dentists and ENTs to come together. And then he ended up asking me to do 3 presentations on pediatric. Came to be a really good meeting, but I wanted to get their perception of what their criteria is, which is basically this question, what's the criteria? Well, to be honest, it varies dramatically. And as Ed's saying, so much of it is, if we can correct the things that produce it, but except in life-threatening situations. And I think that's probably the best advice, because the paper, the research that we're trying to do right now, we're meeting May 2nd with the physicians, Dr. Bhattacharjee and Judy Owens, and myself to try to work out parameters as to what situations would require actual surgery and which situations could be referred to dentists or other adjunct therapies. That's to be determined. So there is no real clear cut, you do it for this, you don't do it for that at this point in time. If we just barely are getting understanding and corrective therapies for adults in the field of sleep medicine, which has only been around, since effectively the 80s when, the CPAP was developed. And so here we are, we're focused on adults, and we've forgotten that the children can't breathe. And that's even earlier in the treatment plans and thought process. So what we're sharing with you, what we're doing, this is on the tip of the spear of therapy, and we hope in the future to standardize care so that there is a protocol for addressing these things. And currently, there really isn't, but that's what we're hoping to do with continued research. So I want to say thank you. I hope you and your families stay well and safe, and we're all going to get through this. It's a terrible strain, but keep the faith, and I wish you the best, and look forward to Dr. Rita Abdel-Fattah's presentation coming up on Wednesday. Terrific presenter with just a tremendous education on the medical legal aspects of what we're doing, which are very important right now. So I wish you all, Ed, that was a wonderful presentation. Thank you so much.
Thank you, gentlemen, very much for being on this and sharing all that wealth of knowledge. And we look forward to reconnecting with all of our AACP members over the next few days, as well as upcoming presentations. Don't forget to check your email as well as social media, because we are definitely getting more involved with webinars. So thank you guys so much.
All right, thank you.
Pleasure.